Good evening, friends. We now have a very interesting session on complex distal and radius fractures. We all know that these distal and radius fractures are one of the commonest things that we see in practice. And despite all the knowledge and all the experience that we have garnered, we all have burnt our fingers with these cases, and they have been a nightmare at some point of time. So today we are going to present 6 very interesting case scenarios which we commonly see in practice and learn from our esteemed faculty the way to manage them. To start the session, we have Dr. Anil Bhat from Manipal, who will be presenting his case of a very distal shear fracture, distal radius. Dr. Anil Bhat.
Thank you, Dr. Satish. This is a 22-year-old lady, our own echo technician working in our hospital, falls from a scooter and comes with this deformity and this swelling here, some abrasions, but it was not an open injury. There was no communication with the fracture site. These are our initial x-rays. You would see looks a little disturbing, especially if I look at the carpal bones, especially in the PA view there. And this was the lateral view. And I insisted for an oblique view because I wanted to see what was happening, especially at the radiocarpal joint. And you would see that that's a very small, tiny fragment there holding on to the carpus there, right? And this part is probably still intact here at this point here. And these were the CT scans. And again, this tiny fragment here. And the carpus is dorsally dislocated here. And you would see the intra-articular fragments here, along with a very major dorsal amount of comminution at this point. So there is dorsal comminution predominantly. There's a big, huge radial styloid chunk here. And there's also this free-floating, what we call as intra-articular fragments here. These were the CT scans. Any opinion from the panel?
Dr. Harpal, would you like to comment on this?
For one thing for sure, this goes as an open reduction and might need an extensile approach. You might need to go onto the lateral surface of the styloid and also on the volar, of course. And you'll have to elevate some intra-articular fragments, then fix it up.
Okay. So your primary approach would be volar approach with an additional lateral approach? Okay.
Lateral would be part of that, but might need a dorsal. I'm not sure if I tackle everything through the volar approach.
Okay.
Sudhir?
You want the X-ray or you want? Yeah.
From the X-rays, it's pretty clear that this is like an avulsion fracture dislocation. If you see the ulnar styloid, it's lying very proximal. So this means it's a very distal fracture, like an avulsion with a dislocation of the carpus. And also when you look at the last where the yellow circle is, you see that tilted articular surface. So these are the things that you need to get back into place, including the ulnar styloid here. Both the styloids are the most important things that you need to put back because this is more a ligamentous injury than a bony injury.
Any thoughts on the carpus itself?
Not really.
Not really. Okay.
My apologies. Actually, I misread the X-ray. It should be a dorsal approach, not the volar.
Okay. Right.
How about a traction view?
A traction view. Okay. This was CT with minus the carpus. The traction view is there. I would come back to that. Shall I proceed with this?
Yeah, please.
Okay. So for me, at least personally, the decision making is always not just with the X-rays and CT, it's always the intra-op behavior. As in, when you start the case, what you would do with, as sir was asking about traction view, under a C-arm, that will be my first point of decision making. That is very, very important. And that is when I would see what is happening with all the different components, which Dr. Warrier said, is it both the styloids, is it the carpus, it is the articular surface, how they are behaving in terms of each other, and that's when the approach comes. And finally, the last part is the implant. So this is the traction view, sir. So that is the first point. As I said, this is just when they give the traction. I'm very happy now the carpus looks fine here. But yes, there are those distal part of the articular surface. There is that bald radial styloid area, the ulnar styloid, which Dr. Warrier pointed out, which is kind of coming there here. And I think the tipping point for decision making is this, when you actually move and see what is happening with this. You see that ulnar styloid, if you see that, it makes me happy because it's coming back here. I know that there is that major ligament of the TFCC is intact, but there is a problem here in this area. And the lateral view is very interesting if you see where the carpus is moving and what is holding it and what is completely intact. So if you see, if you completely go to the ulnar palmar flexion there, it's almost the carpus doesn't move out there. Means for me that ligamentous structures on the capsule there is probably quite intact, but on the dorsal side definitely there's a problem. So my tipping point now would be that I will go dorsal approach. I won't be going on to the ulnar approach at all. So we went on to the dorsal approach here, a very flimsy fragment there, and we need to really open up the capsule actually to go into and see what it is. My first wire usually is a raft wire in these patients, where I would try to get some support, a scaffold for my construction of the entire radius itself. It has to be bit by bit over one or over each other, and then I try to get in maybe a couple of other wires there, and the dorsal plate comes in. You see what's happening to the radial ulnar styloid. It's very, very interesting how this fracture starts behaving. And once that fragment comes in there properly here, the dorsal ulnar corner fragment which is sitting there nicely here, and then I hold on to this area, very, very important area, the lunate facet, which is the sigmoid notch area. The ulnar styloid is completely come back here at this point, and then I try to get in the lateral plate here because I want to catch this particular fragment here. And that's how some amount of, at least a neutral is what we expect, especially in distal rim or distal shear fractures. You don't really get the palmar tilt. Very difficult to reconstruct the palmar tilt. A neutral is acceptable. Most important is to suture back all that soft tissue, especially the capsule, the dorsal capsule, through your plate if you have a hole there left, and the lateral plate sitting there, single approach. You can use both of these, access both of these, right? And I still, at the end of, as any surgeon would, I want to sleep count, so I just still put those two K wires and came out at the end of it. Somehow it happens all the time. Okay, this is a 6 months follow-up here. Look at the articular surface. Look at the ulnar styloid, which is healed beautifully. There she is, 6 months, she's gone back to her work completely, right? She does her echo in our wards. Full range of pronation and supination there. So these are very distal fractures which can, and they're almost like dislocations. These are almost, this 2B is the radiocarpal dislocation here. Just one more minute. And there is an algorithm, but probably ours fell into this 2B where the dorsal plating was what is acquired. So very high energy distal shear fractures also behaves like radiocarpal dislocations for all practical purposes. And fractures are always basically soft tissue injuries with bony fragments. If you remember this particular photo and see the ligaments, and that's very, very important when you're treating this very shear fractures, distal fractures. Thank you so much.
Thank you, Dr. Anil. That was an interesting case. Our next case, Dr. Sudhir, will show us a fragment, a die punch fragment fracture.
Thanks, Satish. That was a difficult one. This promises not to be as difficult as that. This doesn't look very ominous, does it? So many of us would be tempted to treat this conservatively. Anyone on the panel would leave this in a plaster? No? Just because I'm presenting it? Maybe I left it in a plaster. No? Okay, that fragment is what all of us are worried about. Now, to make out whether this is volar or dorsal, you obviously would require a CT scan. So, opinions now. Anil?
This is the classical, what we call as the Achilles heel of distal radius fracture, which basically is that that lunate facet fragment, which is displaced and it is collapsed there, carrying the carpus along with it. It is definitely not the Barton's fracture. So we need to make sure that we differentiate between these two things. And this is a very, very slimy, I can say, for all the orthopedic surgeons where, once you miss, within 2-3 months, patient comes with a bad collapse, right? So,
Chandak, sir.
Sorry?
So in this fracture, one typical finding you will always get is a teardrop size which is increased. That should point towards a volar lunate fragment.
So is this by definition a volar Barton fracture?
That's what I was coming to. We've spoken about the lunate, but have we looked at the scaphoid? The middle image with the red circle. So even the scaphoid seems to have punched out something. Hemant?
I think it is behaving like a Barton's fracture, but I think it's a lunate die. It's a wider lunate die punch.
Right, so these are the ones that are a little more complex than just a simple knockdown of the lunate facet, either dorsal or volar, that Melanie had described. So we need to understand how forces go when the bone is intact, how forces would then act when the bone breaks. And that is what Melanie said. Then there was the columnar concept. Putting the two together, you get the four-corner concept, which draws your attention to all four corners that are very important. And then, of course, what Anil was talking about, dependent upon where the ligaments are attached and which will be your key fragment. So we need to identify the main fragment with which the carpus has gone and then reduce and stabilize that fragment first and then assemble everything around it. Right? So it looks like our key fragment is volar and ulnar with which the carpus has moved. So therefore I would go in from the volar side. So that's how I make my choice. So I've got my plate in. Once I push the plate and tighten it down, you see what happens then is that my ulnar fragment is now very well buttressed, but what remains is the radial fragment. Now the radial fragment is still the scaphoid die punch. So this is not only a die punch of the lunate, it's also a die punch involving the scaphoid. So here now you need to push that back in. And how do you push that back in and then drive the wire across? You see the mosquito forceps, that is the handle of the mosquito forceps that's tugging on the K wire to hold the position. So first I reduce it. Now I need to maintain that and yet rotate the K wire. But if I have my glove on it, or like the old Elizarov method with a wet gauze, there's a chance that it will wind up. So I don't want to be there, but I want that bend in the wire while I'm drilling it. There is a danger of the wire breaking, but I'm going to do it a little carefully. So what you need to do is to pull on that, maintaining that position, and then continue drilling in across until you go there. So now you've got your articular surface back where you want. Go and complete the fixation, and then you can get a good result. But the best thing, this is not the same patient, but the best thing you must do when you're dealing with this is to have x-rays of the opposite side, because that is self-audit at its best. And you mustn't forget to do this when you're doing intra-articular bad fractures, so that you know you've restored everything to get good function. So identify the fracture, understand its potential to rob the wrist of its function, and ensure accurate reduction and fix it stably for early rehabilitation. Thank you very much.
Very nice. I call upon Dr. Satish to present his case now.
So, thank you, Dr. Patankar, sir. This is a young boy, about 35, with this kind of a fracture. He was treated by giving a below elbow cast, and this was the X-ray at 2 weeks follow-up. The whole carpus had dislocated. There was a volar dislocation. Now, at this stage, the surgeon thought that he should go in and fix it. So he went down, he did a volar plating, he tried to capture all the fragments with the screws, the X-ray looked fine, and he immobilized. And at 3 weeks, this was the X-ray. The carpus had again dislocated volar buds. Now what?
Dr. Harpal, can you comment?
The first X-ray.
Yeah. They have totally missed out on the, probably CT was not done, and they have totally missed out on the ulnar fragment as in the, that has dislocated. Can you go forward after the one next to the, yeah. You can see the fragment on the volar, the ulnar fragment is not reduced, and even on the lateral view, that's probably the fragment which is carrying the carpus.
Yeah. Patankar, sir?
I would do a CT
What
scan
did you
at this
do
stage.
now?
I would do a CT scan at this.
Dr. Warrior? What would be your plan of management now?
Well, I don't think there's much doubt in what I need to do here. A CT scan with this, with Mars protocol, etc., probably might help. But in any case, I need to go in there, need to get this plate out, because I also think that these screws are not very well positioned. And of course, the ulnar volar fragment has not been held. So I'll need a better fixation on the volar ulnar fragment and a better reduction.
The
before.
surgeon has missed that fragment, although he has put a screw
I would
there.
have missed it. If you can go to the first X-ray, even I would have missed it. But what I normally do before this, yeah, even on this one, I would have missed this. But what I normally do in these, where there is a crushing, is I get a CT scan, like Harpal was saying, because that's where you will see the volar ulnar fragment cracked. And you know that you need to pay special attention to that.
At time.
Traction view, is that what you asked?
Yes,
Dr.
yes.
Patankar, sir, in traction view on the first day X-ray, does it give better information? Can it avoid a CT scan?
On the first day.
So this is what the whole faculty is talking about. This is the volar lunate fragment. You know, it's a very small piece of the ulnar side of distal and radius. The green line is the insertion of the pronator quadratus, and then you have the watershed line. And then a very small area, but that is the receptacle of the lunate or sustentaculum lunatum, which is a very critical corner. So when you're analyzing an X-ray, please pay special attention to this, because if missed, the result can be catastrophic. This is the attachment of the short radiolunate ligament which holds the carpus there. And that's the fragment there which you can see in the lateral view. So late subluxation of these kind of radiocarpal joint warrants direct fixation of that volar lunate fragment, and SOS X-fix for about 3 to 4 weeks. So this is what was done. Fixator was put on table. Now the distal fragment is very small and it is virtually impossible to capture reasonably with any kind of plate, you know, even sometimes the volar rim plate. So you have to fix it with various modalities like taking sutures through the osteotendinous junction or through the SR ligament, which are passed through holes in the plate, and then the plate buttresses the whole fragment without any screw actually in the distal fragment. Various other techniques have been described like screw, separate headless screw also, depending on the size of the fragment. This we don't have the immediate post-op X-ray, but this is about 3 months and the whole thing seems to have healed well. This is the range of motion. So this volar lunate fragment is a very important pillar of support to the carpus. So whenever in doubt, please take a traction view or a CT scan and pay special attention. Smaller the fragments, more treacherous they are, more is the instability and the chances of late subluxation if not fixed. And the stable and secure fixation of the bony fragment with the radiolunate ligament is essential for stability. The next case is Dr. Chandak. He's going to present a very interesting case of a multi-fragmented comminuted lower end radius fracture.
So this was a compound comminuted fracture dislocation, fracture distal end radius, with the bones extruded with mud contamination. And the surgeon who primarily managed this patient, this was the X-ray. So at this point of time, I would like to have opinion from the faculty members. How would they like to proceed this? So it is compound, grade 3B, bones are out with mud contamination.
Dr. Anil?
Uh, of course, the basic principle of debridement, it is how badly contaminated, whether you really want to push it in, without debridement, or you debride and then push it in. That is one first thing. Yeah. Second, you need to look at the neurovascular status in this patient. And finally, the skin cover itself. What is the loss of the skin which patient has? If you have a clinical photograph, that would be nice. I would not put any kind of even K-wires for this. I'll just hold on initially with the debridement and maybe an external fixator based on all those three things which I told you, which is the skin, the neurovascular status, and the amount of contamination.
Yeah, very well pointed out. A good debridement and holding with the X-fix. So this patient was managed at the primary center with debridement, external fixator, and cross pins to hold the fragments, multiple fragments in situ. Any opinions now? Would that be adequate, or you would think, yeah?
The distal radioulnar joint doesn't look very happy.
Yes.
There is a little extra distraction when you see the midcarpal joint. So I don't think this is going to end in a very happy situation. Does require some revision at some time.
So
once
at
the
this
soft
point,
tissue heals.
Yeah, at this point of time, if everything, the wound would have healed, you would have gone with an internal fixation?
I would then assess it at that time, clinically as well as radiologically, and then make my decision.
Right, absolutely. So the patient continued to have pain and discharge in the post-operative period, and during the follow-up, as the distal radioulnar joint was subluxating, the surgeon put up a radioulnar pin. Any opinions now?
The over distraction is still there if you look at the intercarpal spaces, and it is definitely a recipe for a good stiff wrist with CRPS, apart from the DRUJ, which is now an additionally transfixed joint, which again is not a good thing.
Yeah, and as rightly said, that was the problem with the patient, and also had infection.
There's also only one pin in each fragment.
There's only one pin in each fragment.
And what you're going to show next, I just saw that and I thought I should mention
So,
this.
whenever we manage such a patient and if the articular surface is not okay, that we need to step in and do further things. However, this patient continued to had infection. Now, this is the clinical picture at around 3 months. I mean, these are the pictures we got from the mobile of patient. So, at this point of time, what you would like to do? So, X-fix was out. Patient had persistent infection and discharging sinus, sprouting granulation.
Do we have an X-ray, sir, at this?
Yeah.
Without the fixator?
This is the X-ray. So, clinical evidence of infection, radiological evidence of infection, articular part which is not okay, the bones not healing, and possibly the bones now getting badly infected as well, the distal end radius getting infected. So, Dr. Mutha, what would be your strategy now?
Now it is like an osteomyelitis. The joint is more or less gone.
Right.
We have to treat it like any other osteomyelitis, thorough debridement, sequestectomy, some local antibiotic delivery system. I believe this would already be stiff.
It's stiff. It's stiff with fingers quite stiff.
We just treat the local infection with some local antibiotic delivery system and immobilization, but definitely no even a fixator or an implant.
Okay. So this was the picture. When the fixator was removed, patient was continued with dressings, etc. Now the whole necrotic distal end radius is coming out of the wound and it is now exposed to the exterior. The whole distal end radius has got necrotic, it is sequestrated and is out. Now what would be your strategy?
Yeah, I think we should involve another specialty. a microvascular flap and a fibular bone graft. So the microvascular techniques
So-
cover the skin and the bone.
So
Should- I
standard
think
technique of debriding that
Yeah, after
necrotic
that.
bone, remove everything
Yeah.
and get a microvascular flap.
At this stage, I think a large sequestrectomy of the entire sequestering radius segment, an external fixator at this time, good physiotherapy for the hand to get that hand moving, because all we are concentrating is on the bones. We're forgetting that the end organ, the hand, is not being taken care of. I'd get that supple in that period. I'll have something like stimulan or with vancomycin or colistin there, depending upon what the culture says. And then I'd wait. And I'd make my decision after that.
So getting the
Regarding
things out, soft
Get
tissue
infection
settling.
cleared, keep
and-
length, get hand function back, then decide what you want to do for the gap. And whether you want to retain the joint. The joints,
So how do you maintain length during this?
fixator.
Okay. During period of time, you would maintain with the X-fix?
Yes, of course. Has to be. Without stability, he's not going to do anything.
Right. So this was the position where the patient came, OPS discharge, necrotic bone exposed and fingers stiff, and he was in a miserable shape. So this was managed with a complete debridement of the whole distal radius, the whole bone which was necrotic, that was removed, was put on a simple X-fix since and this is the antibiotic distal radius spacer as a part of muscular technique. So what we usually call this technique as a spacer balun. So the cement with one of the KYs inside it into one proximal part and into a distal part. The distal radioulnar joint was clinically not infected. The radiocarpal joint was not infected. So that was managed with a spacer. Quickly, within 3 to 4 weeks, the whole thing settled down, soft tissues settled down.
What are those multiple wires? Looks like sparks inside,
Yeah.
on the lateral view.
So basically, this were the K wires which were holding the metacarpal, and 2 wires were there in the cement. One wire came out from the medial side of the radius, which you are seeing towards the ulna. So that came out from the inside medullary cavity. It just came out, did not retain inside. That was there inside, but there was no clinical infection. So this settled down, and after the ESR, CRP, etc., all declined, he had a good soft tissue. The skin cover was quite okay now, and the mascule was converted into mascule 2 at around 6 weeks. The graft was taken out from the iliac crest. Since the soft tissue did not permit a long plate there, we had to put a plate at the end of the graft, and the distal end was just managed with simple KYs entangling the distal fragment. So this was the picture at 6 weeks. This is what is the picture at around 3 to 4 months post surgery, and it is healing down. Responded well. The point of presenting is whenever there is deep bone infection, the whole necrotic segment of bone has to come out. There has to be a local antibiotic delivery for a good antibiotic elution, whatever the patient's sensitivity towards the bugs is, and then X-fix or internal fixation. So this was a picture. This is a final picture where he healed down, and the last picture he sent during the lockdown was this. He was able to carry out his farming activity, though he did not have a complete range of motion. The video he could not send, but settled down. So whenever we have a compound fracture, look into a complete debridement, have an effective hold. If the bones are necrotic, excise as Dr. Was suggested. If the bones are not surviving and if they are badly contaminated, remove them. We have a chance to successively manage them in the muscular technique later on. That was replaced with bone. So as you can see, so no, this was a iliac crest graft, and interestingly, the iliac crest of the opposite side fits radius very well. It makes the same shape, the opposite side rather than the same side. That fits very.
It's a wonderful case. A
Thank you
tough
so much.
situation. Yeah. Call upon Dr. Harpal to present his case.
Hi, good evening. I'll try to keep you awake after the complicated cases, plating and redo platings. He's a 47-year-old male, general surgeon by profession, working as a professor in a medical college. Slipped down, got a call. So we brought him, took this x-rays in the emergency. How many of you will like to plate from the panelist? Plate. 4 platings. Satish, plating? How many of you will like to plate him? Majority. So it's democracy, but not always. Again, like Dr. Anil said, we took the patient into the OR under anesthesia. When we stretched it out, we got 100% reduction. And reduction was stable. Now, how do we proceed? Still want a plate?
I ask you, why not plate?
सर मैं दिखाऊंगा क्यों नहीं plate? Yeah. So this is the reduction we got. नहीं यही. This is after the K-wire fixation. Now anybody who feels this should be revised?
We actually, yes, this looks very good, but I think it needs monitoring. If it's K-wires, then you should monitor with serial X-rays.
Agree. Dr. Sudhir, now what are your thoughts after looking at this X-ray? Patient has come to you from Punjab to take a second opinion.
And he has been treated by Professor Selhi. So I will look at this and I'll tell the patient I'm going to take serial x-rays because you've got a good reduction, the pins seem to be stable, keep moving your fingers, keep moving your shoulders and elbow, and every week I'm going to get an x-ray. And if I see any shift in serial x-rays, I'll change my opinion.
And absolutely, that's what we did. He went on to heal. We took the wires out and started on aggressive physiotherapy. This is the X-ray with fracture united. Any thoughts on this? Any corrective procedure that you think he's likely to need?
The radial height is still not achieved. If you see, and the distal radial ulnar joint is still not congruent. So clinically, I need to check what is the patient's range of motion, both radiocarpal and distal radial ulnar joint, and then take a decision on that. But yes, of course, now the only thing is to mobilize, allow him to get back to his work and see the disability maybe at 3 months or 6 months, and then take a decision on that.
How long would you immobilize him, and how would you immobilize him in a plaster? Post K-wiring.
It's with the K-wires, it's just a brace, removable brace from Tynor or Visco or others.
No plaster support.
No plasters. This is the final result. He's a laparoscopic surgeon, happens to be my elder brother. He had planned for plating, but after getting a good reduction, didn't want to violate his hand and proceeded with this. He's elder to me. He's still going strong with his laparoscopic and abdominal surgeries and thoracic surgeries. With, I would say, almost full range of movement.
This is at 6 months.
Yeah,
This is at 6 months.
yeah.
So we need to wait and see
No,
what happens at 1 year. And
this
then-
is 2012.
Oh, this is an old one.
Yeah. More than 10 years old.
Since he's your brother, how frequently did you follow him up post-operatively? Every day?
We live across the road from each other. And we work in the same hospital. We do clinic in the same place. Like he said, every week. I was going to the X-ray radiology with him, get an X-ray done to my satisfaction, with the elbow lift, elbow on the this thing and wrist lifted and that bang on laterals to be sure there's nothing going wrong.
A fantastic result, clinical, absolutely fine, a very happy patient, a very happy surgeon. But this story doesn't end every time.
I'm showing further. We'll go further. So the treatment algorithm is you must achieve 100% reduction. If you cannot achieve reduction, wires are not a messiah. Open and achieve a reduction. I'm no way recommending that wires will take care of your malreductions. Radial styloid wires, there are two methods of going with this procedure. Either you hold with the radial styloid, you have seen the other faculty also, they put wires from the styloid first, hold on to the reduction, assess your reduction at every step, every step. If it's displacing, it's not stable, abandon the procedure and go ahead with the plating. Then followed by dorsal wires. On the other side, there's another method where you first put the intrafocal wires, achieve the reduction, and then stabilize with the radial styloid wires. So do as you feel comfortable or what works in your hand. I'm not trying to say one is better over the other. They are both methods. And depending on the patient, you can use either of the two. Let me show you another case. Again, another patient, displaced fracture. She's a lady, borderline osteoporotic, means she's 55. That's when they suffered this injury. Was able to reduce it. Now this has two styloid wires and two dorsal focal wires. Went on to have a very good result. The story is not the same every time. Now look at this case. The reduction wasn't accurate. It's the overconfidence or it's lack of proper x-rays or lack of commitment. Yeah. So I'll just conclude. These things we know have to be achieved. In K-wire fixation, if your fracture is amenable to K-wires, you should be able to achieve the volar hook. The case where I failed, I did not have a volar hook. Your volar cortex should be intact. If it's not intact, you can't hitch it over it. Don't proceed with the K-wires. You will lose your reduction. Thank you.
In your opinion, how long after the injury would you attempt a K? After the so in your experience, how long have you done? 7 days, 10 days post injury? No, okay.
Okay.
This was a case of a 57-year-old politician who presented to me after about, he was injured in 2015 with a comminuted extraarticular fracture. He was treated in Mumbai with these K-wires. The K-wires were removed after 2 months by another surgeon. And then he presented after 6 months with this fracture. I would ask for opinions. He had clinically a weak grip. He had painful deformity for which actually he came. His grip was weak, but he's got very good flexion extension of the fingers, and his forearm rotations were painful. If the reduction is not good, I think 6 weeks is not enough.
Can you go back on those x-rays? So this is an intra-articular fracture. Why we don't bother about the DRUJ when we talk about intra and extra-articular? That is the beginning of the problem. When you look at this one, you realize that the DRUJ is not where it should be. And I think that this should be addressed as an extra-articular. That's what Frickman classification drew our attention to.
This was extra-articular. This radius was articular surface was intact.
The radius articular surface is intact, but the DRUJ, if you see the second image, so that's what I'm saying, that when we talk about intra-articular, there are two joints.
Yeah, agreed.
So the second joint is out of place. For me, it's unstable right from here.
So we all agree that K-wiring was not a proper choice in this case because of the combination and the intra-articular element in this. And this is how we presented. With multiple medical problems also and multiple opinions he has taken, ultimately he decided to get operated with me. And so we took him up by the volar approach, and that is the clinical deformity. And so I opened it from the volar side. There was a huge, you can see that the radiocarpal joint looks quite good. We could even get a reduction of the radioulnar joint. There was a huge gap here. And now the big problem was he had not consented for a iliac crest bone graft. So he said, I don't want to have any painful area because he wants to attend a meeting, political meeting next day after the surgery. So he said he was consenting for a olecranon graft or any other graft or even Kronos, but no iliac crest graft.
Was this a fixator assisted
No,
correction?
no. It was 2 ward boy assisted reduction. Yeah. So I put in a distal radius plate and I put some corticocancerous graft from the olecranon and supplemented it Kronos and immobilized it in a above elbow slab kept in supination for about 6 to 8 weeks. And this is the 3-year post-op. He ultimately came after suture removal, he came directly after 1 year. And this is the 3-year post-op result.
One point you pointed out was a very important point, that is keep him in supination after the surgery. That was a very important clue.
Yeah, because I said as a bargain or barter for not permitting me iliac crest bone graft, I want to keep him in a above elbow slab for in supination. I would have kept it even if he had consented for iliac crest graft anyway. Time for some questions? Yeah, we have got 2 minutes for questions from the audience.
If I ask you a question, given a displaced Colles fracture, your first choice nowadays always would be plate, or you would still consider KYS in certain cases?
No, my first choice now is a plate.
Why that has changed over a period of years now?
Because actually in elderly, or I look at the X-ray, if there is an element of comminution and if I feel that I cannot get the reduction of that volar beak or volar cortex, then I go in for plate. It did not be a variable angle plate, it did not be a imported plate, it did not be a costly plate. Provided a plate is of a good profile, the instrument systems are good, I would go in even for a local plate, but it has to be a plate.
So the question, sir, is not about K-wire versus plate. Sometimes the question comes between a cast and a K-wire. I mean, that is more difficult for us because...
Yes.
So what is your choice, sir? When you have a undisplaced or a minimally displaced extraarticular fracture, when would you want to put a K-wire instead of a cast?
If I have to give a cast, I would give a cast giving some overcorrection and an above elbow support. At least even if I treat it in the cast, I would definitely give an above elbow extension for 3 weeks so that I ensure that it doesn't slip. And I always have that consent for or preparedness or counseling for a plate ready. Oh, once in a week, definitely. With an X-ray, no C-arm images. Only X-ray taken personally, multiple views of X-rays, 3 to 4 views. Yeah, they are very good. I feed my ward boys well. Yeah.
So with this, this brings an end to this session. I hope you like the cases and I hope you have learned something. I wish to thank the esteemed faculty for sharing such wonderful cases and their experience. And I also want to thank our chairpersons for overseeing this session so beautifully. Thank you.